In the oncology ward, patient stability is an illusion. When a patient with an active malignancy begins to crash hemodynamically or suddenly develops catastrophic neurological deficits, the standard diagnostic playbook is suspended. This introduces the core concept of preemptive acute management for Step 2 CK. In these high-stakes scenarios, initiating definitive pharmacological intervention must frequently precede confirmatory imaging. You do not wait for the scan to start the life-saving drug. The USMLE rigorously tests this principle across 3 primary pathologies: tumor lysis syndrome, superior vena cava syndrome, and epidural spinal cord compression. The diagnostic challenge lies in differentiating these true emergencies from their clinical mimickers. You must rely on strict biochemical markers and precise anatomical divergence points to make the correct call. Our objective here is to deconstruct the exact cellular mechanisms, identify the management traps, and map the rigid diagnostic sequences required to resolve each condition. To simulate the Step 2 CK environment, we will confront these pathologies through integrated third-order clinical vignettes. Success in this testing format requires isolating the next best step logic amidst high-noise, high-pressure datasets. In oncologic emergencies, diagnostic hesitation translates directly to irreversible tissue death. We begin with the cellular bedrock of tumor lysis syndrome. This pathology typically triggers immediately following the initiation of cytotoxic chemotherapy in high-turnover malignancies, such as acute leukemias, where a massive volume of neoplastic cells are rapidly lysing at once. This cellular destruction generates a massive outward wave of intracellular contents into the patient's bloodstream, specifically dumping massive loads of potassium, phosphate, and purine nucleic acids, which metabolize into uric acid. This creates the biochemical triad of tumor lysis syndrome: severe hyperkalemia, hyperphosphatemia, and hyperuricemia. The excess phosphate aggressively binds to circulating serum calcium, driving a secondary severe hypocalcemia. The immediate threat targets the kidneys. Uric acid and calcium phosphate complexes precipitate directly within the renal tubules. This physical obstruction drives a rapid acute oliguric kidney injury. To prevent this crystal nephropathy, aggressive intravenous hydration is the absolute first-line prophylactic mandate before chemotherapy even begins. Pharmacologically, you must differentiate between 2 agents. Allopurinol, a xanthine oxidase inhibitor, blocks the formation of uric acid, making it purely prophylactic. Rasburicase, a recombinant urate oxidase, breaks down already established uric acid, making it the acute rescue therapy. Step 2 CK will frequently test your ability to contrast tumor lysis syndrome with another common oncologic renal failure, multiple myeloma cast nephropathy. This radiograph shows the classic punched-out lytic lesions of multiple myeloma. Unlike tumor lysis syndrome, which is an acute crystal-driven event triggered by chemotherapy, myeloma nephropathy is a slower, systemic process driven by Bence-Jones light chain proteins forming obstructive casts independent of cytotoxic agents. Consider this integrated assessment. A leukemia patient develops peaked T-waves, severe hypocalcemia, and acute renal failure 24 hours after starting chemotherapy. What is the immediate pharmacological intervention to reverse the acute kidney injury? Option A, calcium gluconate, is incorrect. While it stabilizes the myocardium against hyperkalemia, it does not isolate or reverse the primary obstructive mechanism causing the acute kidney injury. Option B, allopurinol, is ineffective here. It is strictly prophylactic and cannot clear the uric acid crystals that have already precipitated in the renal tubules. Option C, rasburicase, is the correct answer. It rapidly clears established serum uric acid, directly resolving the obstructive nephropathy caused by the tumor lysis cascade. Mastering Step 2 CK pharmacology questions on this topic requires separating prophylaxis with allopurinol from acute rescue with rasburicase. We shift our focus to structural oncologic emergencies, specifically the external compression of the thin-walled superior vena cava. The mechanism here is anatomical. A right-sided bronchogenic carcinoma, particularly small cell lung cancer, or a non-Hodgkin lymphoma mass expands and physically crushes the surrounding vasculature. This generates a highly specific clinical signature. The obstruction forces retrograde blood flow, causing strictly localized venous engorgement confined to the upper body. Physical exam findings include facial plethora, severe upper extremity edema, pronounced jugular venous distension, and Pemberton sign, where raising both arms induces flushing and inspiratory stridor. You must quickly differentiate superior vena cava syndrome from cardiac tamponade, as both pathologies present with profound JVD and dyspnea. The critical divergence point is hemodynamics. Tamponade features severe hypotension and muffled heart sounds due to restricted cardiac output. Superior vena cava syndrome maintains normal systemic blood pressure, with edema strictly isolated above the chest. This hemodynamic stability dictates the diagnostic sequence. While a chest X-ray is the initial screen, a contrast-enhanced CT of the chest is definitively required to map the anatomical boundaries of the compression before any intervention can occur. Consider this assessment. A 60-year-old smoker presents with normal vitals, headache, facial swelling, and prominent chest veins. What is the next best step? Options A and C are incorrect. Diuretics worsen hemodynamics without fixing the physical compression, and an echocardiogram targets tamponade, which is ruled out by the patient's normal blood pressure. Option B, contrast CT chest, is the correct answer. We eliminate D and E because definitive treatments like radiation or endovascular stenting cannot be safely performed without precise radiological mapping of the anatomy. In hemodynamically stable superior vena cava syndrome, securing anatomical mapping via CT overrides the urge to empirically treat the symptoms. We turn now to the most time-sensitive neurologic oncologic emergency, neoplastic epidural spinal cord compression. This is heavily associated with metastatic disease from breast, lung, and prostate cancers. The physical mechanism is straightforward but devastating. A metastatic mass invades the epidural space, crushing the spinal cord and generating localized destructive edema. The neurological cascade begins with progressive focal back pain. Crucially, this pain strictly worsens at night or when the patient is in the supine position. From there, it rapidly progresses into bilateral lower extremity weakness, sensory loss, and finally, late-stage bowel and bladder incontinence. The clinical exam requires you to identify the anatomical level of the lesion by distinguishing true cord compression from cauda equina syndrome. Thoracic and cervical cord compression yields upper motor neuron signs, such as hyperreflexia and upgoing plantar reflexes. Compression below L2 yields lower motor neuron signs, manifesting as areflexia and flaccid weakness. There is an absolute pharmacological rule here. If epidural spinal cord compression is strongly suspected, high-dose intravenous dexamethasone must be administered immediately. These steroids must be given before obtaining the confirmatory MRI. The goal is to urgently decrease peritumoral edema and preserve the spinal tracts while diagnostic imaging is arranged. This brings us to our final integrated assessment. A patient with metastatic breast cancer presents with focal back pain, worse at night, 4 out of 5 lower extremity strength, and 3+ deep tendon reflexes. Highlighting the question stem, the hyperreflexia confirms this is an upper motor neuron lesion, perfectly consistent with acute cord compression. Although an MRI of the spine is the definitive confirmatory test, selecting it as the next best step is incorrect. Sending the patient to the scanner without pharmacotherapy delays the intervention required to prevent irreversible paraplegia. Looking at the provided explanation, IV dexamethasone is the correct answer. It acts as an emergency bridge to definitively decrease spinal cord edema prior to decompressive surgery or radiotherapy. In suspected epidural spinal cord compression, empirical pharmacotherapy takes absolute precedence over definitive radiological confirmation. Stepping back, we view the holistic landscape of oncologic emergencies. This matrix summarizes the discrete logic to bypass NBME traps. For tumor lysis syndrome, the rule is aggressive IV hydration, utilizing allopurinol for prophylaxis, but deploying raspberry case for acute rescue. For superior vena cava syndrome, the rule is recognizing hemodynamic stability, allowing you to obtain necessary CT mapping before stenting. For epidural spinal cord compression, the rule is isolating upper motor neuron signs and administering IV dexamethasone before sending the patient to the MRI scanner. The Step 2 CK exam tests your mastery of the sequence of actions just as heavily as your ability to make the diagnosis itself. Knowing the pathophysiology of a disease is useless if you fail to prioritize the immediate intervention that preserves the patient's mobility or life. In the high-noise environment of an oncologic crisis, definitive management waits for no scan.